All right, so for these EKGs, you're going to tell me the rhythm. You're going to tell me what are you going to assess. I think all of these have some, this patient's probably not looking great. So what are you going to assess in this patient? And what is the cause of this rhythm? What are some possible causes you might think about? And then if it is what kind of rhythm would you be assessing SVT with aberrancy? Be a rhythm that is fast or slow? Be fast, right? And why you would think aberrant would be because of what? It is what kind of morphology? Wide, right? So yeah, so if it's just narrow and fast, you're like, well, that's maybe sinus tach, AFib, might be PSVT, might be AV nodal reentry tachycardia, might be Wolff-Parkinson-White. But if it's wide, then we know it could be VTach, and we are going to assume it's VTach until proven otherwise. But we have little tools that we can use to see that it is VTach or not, right? And that changes our treatment too, right? Because our treatment is going to be either ABCD therapy or amiodarone, right? Usually, right? You can do lidocaine, some other fancy stuff too. All right, so then the final thing to ask is what is the treatment for this rhythm, right? So there's some rhythms that can have non-pharmacological treatment, only one, and everything else usually needs medications, and most of the medications we give are going to cause hypotension. So when that's the case, we always eyeball, are they hypotensive? Then they might need to be shocked, and that shock can be synchronized or unsynchronized, or cardioverted or defibrillated. Technically, defibrillation is unsynchronized cardioversion, right? All right, so number one, who has number one? Top left, what is this? AFib, any other flavors? So when we describe AFib, we give it three flavors, right? So there's rate controlled, which is normal, 60 to 100. There's slow ventricular response if it's less than 60, or rapid ventricular response if it's greater than 100, right? So there's AFib, RVR, right? And then what are you going to assess in this patient? Your patient goes into this rhythm, what are you going to do? It's like, you got this, champ.
Shortness of breath, low blood pressure, confusion.
Good. So chest pain, shortness of breath, hypotension, or confusion, right? And if they're hypotensive, that's going to change gears, right? That means we're going to do what if they're hypotensive? Cardiovert, or synchronized cardioversion, right? We'll try medications as long as the blood pressure is okay. And even sometimes intensives will start like neosynephrine to support the blood pressure in the meantime, so we can give some of the antiarrhythmics. All right. So yeah. So the cause of this we said would be what?
Old age, pericarditis, hyperthyroidism, drugs.
Good. Hyperthyroid drugs, right? They took some meth or cocaine, some of that effect, or withdrawing from drugs, right? Opiates, etc., or alcohol even. Yeah, and then just anything that stimulates the SNS. So you mentioned one of them. Which one stimulates the SNS?
Drugs, cocaine.
Yeah, that's an SNS mimic. But what actually stimulates the SNS? Like a patient's sick in the ICU, they have something going on that makes them go into AFib RVR. They have what going on? You're like, oh shoot, I'm gonna fix that. It could be just low blood pressure, right? Low blood pressure stimulates the SNS. It fires off and your AFib RVR. Now your blood pressure is even lower, right? But another thing could be like hypoxia, right? They're getting hypoxic, or they're getting too much CO2 buildup, or their pH is going down because their shock is getting worse and their lactate's going up, right? Or they're hypoglycemic, or they're getting more dehydrated because they're hyperglycemic, or they have a fever going on. All these things stimulate the SNS. So usually we're looking for those physiological reasons, and we try to fix those underlying problems because that's an easy fix, right? Otherwise, if that isn't, the patient's not febrile, not hypoxic, not hypoglycemic, not hyperglycemic, not the regular stuff we can fix at the bedside, we need to get orders for meds, such as if they have a good blood pressure. Good. ABCD therapy, right? So to get a amiodarone, they get beta blocker, right? They get calcium channel blocker, specifically non-DHP1, and they get digoxin, right? All right, very good. Let's see if I have the same idea from last year. Yep. And then what about the next one? What's number 2 here? Idioventricular. So idioventricular is wide complex. So this is not wide enough. It might be getting there, but there is definitely a conduction delay happening. But this just looks like we got what? We got a P wave followed by a QRS. So we don't have like a 3rd degree block or anything fancy. It just looks like a really, really slow sinus bradying, right? It looks like a really, really slow sinus bradying. That's definitely worrisome, right? I'm going up then down, right? That's concerning when I have T waves go up and down, right? If they're down then up, then I'm cool with that. But like this one over here is going down then up, right? Whereas what's on the left is going up and down. That's not a great T wave to write home about. So this is, a sinus Brady of some sort. Is there a block? No, it's less than 0.20. So that everything's getting conducted correctly. So what else are you going to assess in this patient? Your patient goes in this rhythm. If they go from this rhythm to this rhythm, I'm very concerned, right? That means they have a severe something going on, right? Such as, what are the kind of leading to causes? But what would you assess first?
Electrolytes.
Yeah, the causes, right? So the causes of bradycardias are? Die, right? Their patient's trying to die. There's too many drugs on board, right? So they got too many of the ABCD drugs. So maybe you like, I know what to do. I'm going to give amiodarone. I'm going to give a beta blocker. I'm going to give the digoxin push, and now you got this rhythm. At least they converted, right? You clock out. I'm done, right? They converted, right? So, but the rate's a little bit low, right? So drugs could have caused it, right? Such as ABCD drugs or AV node blocking drugs. All right, and then as far as cause, we said DIE, drugs. What's the I stand for? Ischemia, right? They have an ischemic event from a MI, right? They also like a severe intracranial hemorrhage can cause this too. But then what's E? Electrolytes, right? So you'd be assessing what? Potassium level especially, right? That's one that usually creeps up the fastest, right? Yes, hypermagnesemia could cause it too, all right? All right, so yes, so what else? So is this SVT or anything like that? No, that's only for fast rhythms, right? And then the fix we said was? You could pace them, but we're going to give them a little trial atropine. Atropine works for most bradycardias unless you have an interventricular rhythm or a junction rhythm, probably not going to work great, or if you have really high-grade block, it's not going to work great. But for something that has a P and QRS, you can upregulate that AV node to make it work, right? Obviously, the fix is probably going to take away the amiodarone infusion or the diazepam infusion if that's running already. Okay. Other things you can do to fix this, like you said, was to pace them, right? So what would you do first? What kind of pacer variety? Did you like schedule them for a permanent pacemaker in the morning? Yeah, probably do transcutaneous first. And you would do that if they had what going on. Why would you say, oh, let's get the Zoll, let's get the couch cart to the bedside, let's put the pads on. When would you say you need to do that? Versus like, we'll continue to monitor. If you're getting hypotensive, that's where you're gonna pull the trigger and say, let's get the Zoll pads on them, and call the provider and say, can we start pacing them because I'm hypotensive and such. Right? And they might say, well, let's try atropine and see if that works. But good luck, or good fortune, it's in the crash cart, right? So we can grab atropine right out of the crash cart. All right, what did I say here? Yep, symptomatic atropine. You can do an infusion of dopamine and epinephrine if we need to. Okay, and then what do we got next? Number 3. Who has number 3? All right, what do you say for this one?
It goes from sinus rhythm to polymorphic VTAC.
Good. It's going down and up. And if you're French, you don't call it torsades. You say what? You say torsade des points. All right. So it's a torsades rhythm. So what are we looking for assessment-wise? What are we going to assess in this patient if someone goes to the torsades? You can you can definitely assess the pulse, because sometimes torsades it's just like a run of it and it comes right back, right? Just like 6 seconds and it comes right back to it. So you can keep an eye on but definitely if the rhythm goes back to normal. But yeah, definitely looking for a pulse. All right, are you okay? Are you okay? And if they keep sustaining that, what are you going to do? Sustained torsades. What will you do next? You could do amio, but that might take, I guess, get approved by pharmacy. Then they have to improve in the Pyxis, and then you realize you forgot your password at home, and you got all the super glue on your thumbs because you're just doing a craft. So yeah, there could be reasons why you can't get amiodarone right away, right? But it is in the crash cart if you need it. Yeah, magnesium is a good option, right? Also, what else can we do? You can shock it, right? You shock pulseless VTACs and VFibs, and this is a flavor of VTAC, right? This polymorphic VTAC, like you said. All right, but going back to causes. What causes? We said low mag, right? So you give mag. What's another cause of this? Yeah, this QT looks pretty prolonged. One way you can estimate a QT if it's greater than 2/3 the distance between the two R to R's, but nobody can get that. That doesn't, unless you have calipers, that's not going to be hard to assess. So you assess not the QT, but the QT what? QTC, right? And then, so yes, we have torsades in our hands. The cause could be a prolonged QT, a low mag, or other low electrolytes such as calcium. Yeah, low calcium also, and low potassium. Those 3 could cause potentiate torsades. All right, and then is this SVT with aberrancy? No, this is VTAC. This is definitely VTAC. It's polymorphic VTAC. All right, there's no SVT that looks like that. All right, and we described the treatment already. Okay, and then what else? What's next? We got this guy down here, number 4. What do we say for this one?
You said SVT.
Good. So why is it not sinus tach?
The rate?
The rate, yeah, maybe. Usually sinus tachs don't go more than 160, 170, but there are some champs out there, some Guinness Book World Record, holders who have a sinus tach that's more than 160, more than 150. Another key reason is we have what's missing here. We're missing P waves, right? You can think of PSVT or paroxysmal SVT as a fast junctional rhythm, right? So we got PSVT happening here. So what are you going to assess in this patient if they go into this rhythm?
Pulse, blood pressure.
Good. You get a set of vitals, pulse and blood pressure, right? What's the blood pressure going to tell you?
If he's hypotensive, we got a cardiac burst.
Yeah. So that's going to decide whether we're going to do just, if they're hypotensive, like you said, they need to be cardioverted, right? But if they're not hypotensive, what can I do?
You could probably give adenosine.
You could do adenosine, but this is the only rhythm we can do what for? Concho or non-pharmacological reason, non-pharmacological intervention. So if they're aged less than 45, we can do what? Carotid. Bilateral or unilateral? Unilateral carotid massage, right? And then we can also, what's the preferred method now is the modified Valsalva, which is what maneuver? Where you have them blow into a syringe, they lay back with their heads above their head, and then you send them back up, all right? And it breaks the rhythm. All right, anything else? Is this a SVT with aberrancy?
No.
No, why?
The QRS would stay the same.
QRS is narrow, right? QRS is less than 0.12. It's impossible to be aberrancy because the only reason why we would assume it's aberrancy is because we can't tell it between it and VTAC, right? And it and VTAC and SVT with aberrancy have prolonged QRSs, right?
Yeah.
So. All right, so this is there's a difference between a SVT with aberrancy and VTAC is, the similar thing is that they both have prolonged QRSs. This QRS is less than 0.12. It's impossible to be one of these two things, right? All right, then what do we got at the bottom left? Number 5. So it could be VTAC. How do we know it's VTAC and not SVT with aberrancy? So QRS width, right? So both QRSs are wide in both VTAC and SVT with aberrancy. So how do we know it's VTAC?
The QRS association.
Good. AV dissociation. Look at the P wave here and a P wave here, right? So we got P waves in the wrong spots, right? That's AV dissociation. That's the definition of VTAC, right? We have a ventricle doing its own thing, and the P waves are trying to do their own thing too, right? We got a little P wave right there. It looks like it's pretty regular, but it's like on the ST segment, right? Another clue that you have VTAC is that the QRS is greater than 0.16. Here it's 0.12, right? If I look at these guys got like 1, 2, 3 boxes. So it's not quite there yet. So we use some of our other criteria that tell us that we might have a VTAC on our hands. Okay. And then how do you fix it? How do you fix a wide complex tachycardia?
If they're symptomatic.
Yeah, you look at their symptomatic, they might need to be shocked out of it, but before that, if they're good, have a good blood pressure, we do what? Vagal maneuvers are only for, well, technically, yes, if you say it's PSVT, you could do carotid massage, but what else would you do? What medication would you give? Amiodarone, right? That's usually our go-to agent. It's usually not wrong if you say amiodarone for a supraventricular or ventricular tachycardia. All right, the middle one, what do we got for the middle? Number 6. What do we have for that middle one there?
We put a VTAC.
Yes, this looks like VTAC, and why is it not SVT with aberrancy?
Because of the QRS complex are so wide.
Yeah, QRS of how wide? I mean, kind of starts here, right, to there. That is, it looks like a little greater than 0.16. But if it was like just borderline 0.14, how would you tell that it is? Another reason. That's the reason I give you the 12 lead here is because there's something being demonstrated here. They're all looking like this, right? They all have the same direction. That's called concordance, right? So they're all looking the same, all going the same way. That's a sign of VTAC as well. It's all coming from one source. That's kind of overriding everything else. I mean, you could try to hunt for P waves. If you see them, then cool. But I mean, this you could argue maybe there's P waves there. So this looks like VTAC though, because it's concordant. Okay, and how do you fix that? Tell them to stop. And then the next step is then give medications, right? And you can only give medications if their blood pressure is what? Is above 90, right? All right, what else we got? What's the next one down here, number 7?
Second-degree AV block.
So second-degree AV blocks have a dropped QRS, right? So we'd expect to see like a P wave here and a QRS being dropped. You're definitely seeing something going on here, right? But we don't have P waves that are non-conducted. That's the definition of a second-degree block, right? So we have a little episode of activity here, right? Or over here. So a little episode of a little tachycardia, a little run of tachycardia, whether it be a VTAC, like a little run of VTAC, a little run of torsades, a little run of AFib, a little run of, we got to figure out which kind of run it is, right? So the way we tell is by looking at the P waves, right? So the P waves look different than their intrinsic P waves, right? So this would be intrinsic. I'll put an I over it, right? So that's the intrinsic P wave right here. And right there when they go back into their rhythm. And then we have this weird P wave here, right? Does it have just one shape or more than 3 shapes? Or 3 shapes or more, I should say. That's one shape, right? So they call this a what kind of tachycardia? A multifocal or a unifocal? Yeah, and they call that an ectopic atrial tachycardia, or an EAT, right? So EAT, an ectopic atrial tachycardia. They just have a little run of just one little focus is going crazy in the heart, right? Of course, that can churn into AFib. It can convince its friends that, hey, look what I did, right? It's like a little kid driving his grandma's car, okay? So yeah, so it's just a little episode of ectopic atrial tachycardia. And this one, how do you fix this? No, you say, we'll continue to monitor, right? But you are going to look for underlying causes, such as it's not H's and T. You could argue H's and T. H's and T's are severe deficits in what we're looking for, right? That can cause the patient to code. But it's just anything that causes tachycardia, right? That's all we're looking for. Are they a little hypoxic then, where they're not wearing their BiPAP at night like they should, right? And they got a little hypoxic and now they go on a little run? Or are they getting hypoglycemic? Are they getting electrolyte? What electrolyte might be low that caused this to happen? That would cause a little run of tachycardia. It makes the myocardium excitable. No, every heart electrolyte is always K for cardiac, right? You're always taking hypokalemia, what causes tachycardias. It puts you at risk for tachycardia. It doesn't like directly cause it, but hyperkalemia definitely causes bradycardias, right? 100%. All right, so yeah, so we have that's the fix. Or the cause. We're looking for all these things that trigger the SNS, such as got a fever happening. They got some hypoglycemia. They have some hypoxia. They got some low pH brewing. Okay, some acid developing. So we're going to fix the underlying cause. All right, top right. What do we have there? Number 8 now, right? They went into asystolic. Good. They're flatlining. So that's a problem. So we got to look at assessment. What's our next assessment? You say, oh, they're okay. The leads just came off.
Assess for pulse.
Assess for the leads off, but also you're going to go in the room and see if they look okay, right? If they're brushing their teeth, then they're fine, right? But if you're going to assess for a pulse, you're going to see how you're doing. You're going to turn the lights on. You're going to wake some people up, right? You're definitely going to see if the patient is breathing and has a pulse. All right, and then what are the causes of this? Comfort care, not yet. We got to assess there might be some reasons why they developed this, right? If there's a really, really sick patient on CRT on 4 pressors, is like, yeah, that might be, we might have been expecting this, right? But what might be the causes of this? Why are they on 4 pressors and on CRT? We're thinking H's and T's, right? So one of the H's is hyperkalemia, which is the reason for getting dialysis or CRT, right, in the ICU. And what's another H or T? They got really, really hypoxic, right? There's like a severe hypoxia. When you talk about DIE, it's severe ischemia to the heart because of hypoxia, What else? Give me one more. Give me a T.
Oxygen ion.
A T, please.
Thrombus.
Thrombus, right? They developed a acute clot in their heart, right? Or a clot in their where? Pulmonary arteries. That's usually what they think about when they talk about H's and T's. Yeah, you could have a thrombosis of the brain, but it'd have to be like a severe like brainstem involvement for that to get to this level. All right, so then what's our next one here? Yeah, you could argue it's torsades, but definitely, it's definitely something you're going to do what to fix.
This would be, well, it depends, but it's shock.
Yeah, I'd probably shock this, right? I mean, this kind of looks like, a V-fib as well. It does have a shape of torsades, but either way, if it's V-fib or torsades, we are going to do shock, right? Especially if it's sustained. It could be artifact, right? But we don't know. All right, so definitely going to assess, pulse, how they're doing. All right, causes of this, if it was V-fib. Mm-hmm. For cause of V-fib, what would you think the causes might be? So just like above, we're going to do the H's and T's, right? And yeah, if we're going to be doing our treatment for this, before we just did CPR and epi, but if it's V-fib, we could do some extra stuff, such as
Atropine or amiodarone.
so amiodarone, yes, atropine is for bradycardias, right? So amiodarone, yes, we can give. We give after we do 3 other things first, and they're all the same thing. Shock. You can shock them 3 times, like amio, right? 3 syllables. Then we can give a dose of amiodarone, right? Otherwise, you're doing CPR and epi, CPR and epi. And if you notice the monitor, it has this shape when someone's in VFib. They say, oh, they're in VFib arrest, and you notice that shape. Say, hey, this might look like torsades, guys. What do you think we could get some magnesium? And yeah, they're going to say, YOLO, you're already dead. Let's try it. Give it a shot. See if that's the reason for this, right? And other fancy reasons for torsades besides prolonged QT and besides a low mag are MI could do it, ischemia, good. What else? You got RNT phenomenon, so someone was shocking them ahead of time. They had a planned cardioversion, a planned synchronized cardioversion, and someone didn't hit the what button? Someone did not hit the sync button, all right? And that can cause a torsades-like event, okay? Either way, this requires some kind of shock immediately. So you start assess it as VFib. All right, so that's 9. Number 10. What do you got for number 10?
Failure to sense.
Failure to sense. So why is it failure to sense and not failure to pace, failure to capture?
Because it's kind of just going anywhere. There's no specific pattern.
Yeah, it's what? It's too sensitive, right? It's way too sensitive. It's seeing things go off, and it's like, oh, my turn, okay. And it's going to try to elicit a capture of the heart, right? So here it looks like maybe it probably captured it, right? But then over here, it's definitely not capturing. So you could, well, why is it not failure to capture? Capture means there's nothing afterwards, right? And yes, there's nothing afterwards, but it's not where it's supposed to be. So it's not sensing correctly. So this is a failure to sense. All right, what are you going to assess for this patient? You're going to assess their pacemaker's manufacturer, right? And you're going to probably give them a call to interrogate the pacemaker. But in the meantime, you're going to assess them for what? Yeah, chest pain, shortness of breath, hypotension, confusion, because they probably got the pacer for bradycardia of some sort. This doesn't look terribly bradycardic, right? It's like 300, 150. It's like a rate of like 90 to 100. So they're not dying, right? But they could be at risk for their pacer firing on the T wave right here and causing torsades, right? All right, and then what else? Next one, number 11. PSVT, yeah, we could, but I got some pretty solid T waves, pretty solid P waves here before I have a QRS. Some PSVTs can have like inverted T waves or like really, some P waves you might be able to write home about, but so yeah, this rate is pretty fast. You got a rate of like almost 270. So I mean, we'd be going between the 2 of them. If we gave adenosine, we would just see a bradycardia, right? Say, oh, they actually had a sinus rhythm, right? So usually adenosine is given to kind of rule out another rhythm, right? But adenosine will kickstart the heart anyways if it was an SVT, or PSVT, I should say. So this kind of favors tachycardia, but the fact that it's so fast kind of favors PSVT. But yeah, in the meantime, we might try what before we try pharmacological therapy?
Non-pharm, so like Valsalva.
Yeah, so modified Valsalva or ice to the face or something. Okay. So yeah, so these are this, and then what causes this?
Any SNS trigger.
Yeah, any SNS triggers are a good lawyer answer. So what might that be? It's like, sir, are you having an SNS trigger right now? Yeah, I'm very triggered. Yeah, they got an infection brewing, right? They got their antibiotics fell off the previous day, and now they are, they're getting really inflammatory, right? They're getting really febrile. They might be an old guy and can't mount a fever, but they still have the inflammatory markers.
Drugs, severe hypoxia.
So drugs, severe hypoxia, good. All right. So SVT versus A flutter. So you could say, since it's that fast, was this like a really, really fast conducted A flutter? We don't know for sure. All right, and adenosine can help us rule that out. All right, bottom right is number 12. What do we have for this one? Definitely have some ST elevation happening.
Inferior MI.
So inferior wall MI. And then what else is your rhythm interpretation?
It's third degree, or yeah,
Cardiac pressure.
third degree.
I mean, these are, you got 2 boxes there, and I got like 4 boxes there, and then I can't tell if it drops over here. But I mean, is it third degree? It's hard to say. The PR does get longer. And are these P waves marching out? If the P waves did march out, then I could say, yeah, it's a third degree. But if they don't march out and it's getting longer, and then probably the next one might drop, that would be what kind of block? A second degree type 1, yes. So yeah, second degree type 1 would be where PR gets longer and drops. Okay? But it's definitely ST elevation. We don't really worry about that other stuff, but yes, it is a ST elevation. So what needs to be happen? What's the assessment going to be?
Just hemodynamic stability.
Are they having? Is their BP and good, right, with this low heart rate? And then yeah, are they having chest pain? What kind of chest pain?
Substernal.
Yeah, substernal chest pain. That is what?
Radiating.
Right? And also that it's non-positional, right? So does it get better with the leaning forward or something to that effect? Okay. And then the fix is what? Yeah, they might need to go to cath lab, right? They might need to get that stented and opened up. Or if they don't have a cath lab within 120 minutes, we can give what? Heparin, yeah, that's just a Band-Aid. But what's really might work? Has a complication of free wall rupture. Thrombolytics, right? So thrombolytics can be given if there's not a cath lab within 2 hours. Okay. All right, top left, what's this one?
VTAC.
This looks like VTAC. Those circles are pretty suspicious for circling P waves, right? That it shouldn't be where they should be. So this is called what? When the P waves and QRSs don't line up. AV dissociation, right? They are disassociated. They are not associated with each other anymore. They are divorced, right? So this is an AV dissociation. AV dissociation is either a third degree AV block, which is way too fast for, right? The rate is what? Rate is 300, is about 270, right? So on that little QRS complex right there. So 270 AV dissociation is favoring what rhythm? Yeah, the rate of 270 in a wide complex tachycardia with AV dissociation is VTAC, right? Not SVT would not have AV dissociation. If they have an SVT, yes, PSVT doesn't have P waves, but at the same time, when you have like a really fast rhythm, that's SVT, you would have AV dissociation. It'd be P wave QRS at a fast rate. Like the previous slide, we said that was A flutter at a really fast rate. Yeah, that could explain why it's 270. It's like, well, it's no sinus rhythm, never over 160. But then if you realize you slowed it down, you saw some clear A flutter, right? But here you give adenosine, it's not going to work for one, but it's going to, you have a VTAC on our hands, right? So what do we assess someone with VTAC? Yeah, if they have a pulse with this, right? Are they perfusing? What if they have a pulse? What would you do? Defib is for pulseless VTAC. If they have a pulse, we do shock them, but how do we shock them? Gently, yeah, or synchronized, yes. We do a synchronized cardioversion, right? How do you know you're synchronized? Click sync, but how would you know that the sync is active? There's little markers on it, right? It'll see little markers above every QRS, and that will know that it can shock, it needs to shock on the appropriate time and not on the T wave, right? All right, good. And then the cause of this? Yeah, H's and T's. So give me an H and T that hasn't been mentioned yet. Toxins, good. Toxins, hypovolemia, right? So what kind of toxin might have they ingested? Yeah, meth is one, yeah, or grandma's nifedipine, right? So nifedipine has reflexive tachycardia, and then they could have also taken grandma's lidocaine, and they could have blocked their sodium channels and whatnot. But yeah, they ingest it. They could be a toxin or hypovolemia, and why would hypovolemia not just lead to a sinus tach? Why did it lead to a VTAC in this person if they're hypovolemic?
Like renal patient?
Renal maybe, but yeah, but they're hypovolemic. Right, so they're hypovolemic. Why? And they mounted an SNS response. And why didn't they just get sinus tach? Why did they get VTAC?
Concentration of the potassium.
Concentration, maybe, but it's because their heart is messed up, right? They have scar tissue on their heart. They have a heart that's big. They have a heart that's old, and that's why they didn't have just a normal SNS sinus tach, right? SNS went down, did its job, came from the medulla, went down to the heart, and said, "Go faster," right? Because you're hypovolemic, son, right? So then they said, So you're hypovolemic, son, right? So then it says, "Go faster." It's like, "You got it, boss. Put me in, coach." Right? And it's going, and it's like then it goes into a VTAC. That's scar tissue, right? It's trying to run like Forrest Gump, and it's not going to knock off its braces. It's going to, it's going to start stumbling, right? Going into VTAC.
I was going to say old, but it didn't seem right.
Old, you could say they're aged. Okay. All right. Next one.
AFib.
Good. We got some fibrillatory waves right there. And this is what kind of AFib? What flavor? Rate controlled, slow, or fast? It's definitely slow, right? When you have an irregular rhythm, you count the complexes in 6 seconds. 1, 2, 3, 4, 5. It's a rate of 50, right? Which is less than 60, or slow ventricular response. So AFib with slow ventricular response. So what's causing this?
Hypoxia, old age.
So they have an SNS response, maybe, but this is really, we're looking at, when you say hypoxia, what kind of hypoxia are you talking about? PO2 of what? So yeah, probably PO2 of 50, 40, that's going to be leading to a really, really severe hypoxia, right? Regular hypoxia causes tachycardia up top, right? Whereas bradycardia can be caused by DIE, right? Die. So it could be drugs, it could be ischemia or hypoxia, right? Or electrolyte issues, right? So people with AFib have the same response as someone with sinus brady, right? They're both the same. The only difference is someone is elderly or someone has really bad atria or really bad ventricles, and so they don't respond as well to a normal response like a regular person would, right? So you just want to see fast rhythms and slow rhythms as a feature of too much SNS activity or too much of a physiological insult, like with DIE, right? All right, so then what else? The fix is to do what?
What depends on the blood pressure?
Good, depends on the blood pressure. There's like again, if it's a bradycardia with a low blood pressure, what are you going to do? You could cardiovert, but atropine doesn't lower the blood pressure. We can give it a shot with atropine, right? See if that helps, right? But like on the flip side, when we have a tachycardia, yes, you're looking at if blood pressure too low, we're not really going to be giving medications. With like the exception maybe digoxin we can give because it doesn't lower blood pressure. But with with slow rhythms, we can give atropine or give what other medication? Dopamine, good. And what's another one? There's 2 more. Epinephrine, and the fancy one, if you can't afford a pacemaker, and you're at your ER, you can get isoproterenol, right? So you can't afford the $15,000 to $20,000 Zoll machine, then you can buy isoproterenol off the street. No, I'm kidding. You can buy isoproterenol which costs a lot less, and it stimulates or simulates a pacemaker event. It's a beta 1 agonist, right? So this could also be someone who's had too much diltiazem or too much beta blockers or too much digoxin, right? Who has AFib already. So you'd remove the offending agent. So you look at the MAR to see, oh, what happened here? Maybe they have some, maybe they got too many medications building up because they are advanced stage renal disease or they have renal impairment this time. All right, next one.
This one is monomorphic VTAC.
Good, monomorphic VTAC. How you know monomorphic versus polymorphic? What's the difference? So it's the same, but also polymorphic is the torsades picture, right? Where it gets smaller and bigger, right? Like in the previous slide. So this is monomorphic VTAC. It's VTAC for sure. How do we know it's not PSVT?
The absence of P waves.
Well, absence of P waves is PSVT, right?
It's way too wide.
It's way too wide, right? That's okay to say in this classroom. So you're way too wide, right? So yeah, you got a QRS is more than 0.16. So that, and it's, you know, pretty, yeah, SVTs are fast, but this is more than 0.16. We look at the, between each QRS, or even between the nadir here, that is more than 0.16, more than 4 small boxes. All right, so this is VTAC, and what are you going to assess with someone with VTAC? Pulse or no pulse, because the treatment changes if you have a pulse, right? If you have a pulse, what do? We can give medication as long as the blood pressure is good, right? Blood pressure is good, we can give you amio. If there's no pulse, like, oh, I'm going to give amio, right? That's you know, also when you have no pulse, you have no blood pressure, right? So you have no pulse, you're not going to give amio until when? After the 3rd shock, right? We're going to do 3 shocks before we give amio. In that case, if they have no pulse and they have VTAC, what's the treatment? defib as early as possible. In the meantime, before someone's going to find the defibrillator in the unit, that's why you want to have it nearby, right? You want to make, you're going to give what, you're going to do what instead? You can do CPR, right? CPR and epi, and then throw the pads on them and then defibrillate, right? All right, next one. Bottom left here. What do we got here? Failure to capture my heart, right? So it's not capturing the heart, whereas it did over here, right? So it's failure to capture. Failure to pace looks like what? What would failure to pace be?
Spikes with no QRS.
There'd be no spikes at all if it's failure to pace. Failure of the pacemaker to pacemaker, right? So that'd be failure to pace. Failure to sense was in the previous slide, right? So what are you going to assess in this patient? The patient's heart rate is 1, 2, 3, 4 complexes, right? So that's a rate of 40. You can check blood pressure, right? You're going to check to see, are you okay? Are you having chest pain, sir? Right? Ma'am, are you short of breath? Right? And then they say, my daughter, you came to visit me. He's like, I'm not your daughter, I'm a man, right? So then it's going to be someone that might be a little bit confused, right? So you're looking for chest pain, shortness of breath, hypotension, confusion. And then how are you going to fix that?
You pace them.
You're probably going to pace them with a transcutaneous pacemaker. The reason they got the pacemaker in the first place is probably because their AV node is not working, right? So yeah, so probably this one we're going to skip past atropine and start a pacer. We can start dopamine or epinephrine. That can maybe make the rate work better. But really the problem here is the pacemaker, right? The pacemaker is not working, so I need to get another pacer in the meantime. All right, so next one. What is the bottom left there?
We put AFib RVR.
AFib RVR, but we got some P waves pointed out here. What are these? Is this AV dissociation? What's going on? So SVT with aberrancy, we have what would look like what?
Dissociation.
It has AV dissociation, yes, but we have P wave QRS, P wave QRS. Is that dissociation? That's association. Those guys are hanging out. They are going on dates. They are, they got car dates, they got beach dates. They're doing everything together. So why are the P waves being identified? So AFib does not have discernible P waves, right? A-flutter does, but A-flutter has nice, unique P waves. Just usually one site is going crazy. 2 to 1, 3 to 1, 4 to 1, 5 to 1 even. So what's happening?
The speed of wandering atrial.
Wandering atrial is a fast wandering atrial pacemaker. This is a multifocal atrial tachycardia. All right, why is it multifocal? Because we have multiple foci that are creating a P wave in the atria. So imagine our atria looking like this. We have a P wave over here, our SA node. We don't know which one it is. We'll figure it out. We have it over there, 3, 4. We got many different ectopic sites, right? So it's not ectopic atrial tachycardia because that definition is 2 or less different P wave morphologies. This has 3 or 4, right? So that's a multifocal atrial tachycardia. All right, so what would you do to fix this? This would probably be fixed underlying problem, but also you might need to do rate control if we need to get that under control, right? Beta blockers, amiodarone, calcium blockers if it's fast enough. Okay. What else? What's the next one here in the middle?
So that's what we put. It's a wide complex tachycardia.
Good. It's a wide complex tachycardia. How big is the QRS? Greater than 0.12. We got, I mean, it's borderline 0.14 maybe, right? Do we see AV dissociation? There's a pretty regular rhythm. It could be SVT with aberrancy. It's just we don't. I think it's leaning more towards SVT because this bunny ear is one of the fancier criteria we can look at. Right, that left is less than the right. That looks like a right bundle branch pattern. Right, usually when you have a right bundle branch pattern, it's not. Yes, it could be VTAC, but that's when the bunny ears are flipped. Right, that is one of the criteria you look at for someone that has a SVT with aberrancy to see which one it is. Right, so this is leaning more towards SVT with aberrancy because I don't see AV dissociation. I don't see concordance like on the previous slide. Right, the previous slide had a really wide QRS and it had everything looked like it was going the same direction. So what did I describe here? I said VTAC. I beg to differ. I'd probably say SVT with aberrancy. All right, so then what's the bottom one there? This one definitely favors what?
AV dissociation.
Yeah, got AV dissociation. It's all over the place. That P wave is doing whatever it wants, right? So this is definitely leaning towards VTAC, right? And we kind of gone over the causes as well. All right, top right, what is that? Failure to pace, good. So failure to capture, there would be a spike there, but there's not, right? So that's failure for the pacemaker to pacemaker, right? It's not pacing. So this is failure to pace. And what are you going to assess?
The machine.
Make sure the machine's working, right? This is your transvenous pacer. You want to make sure, oh, did anybody change the battery in this thing, right? You realize you got to find a 9-volt battery in a hospital. You know, that's super huge. You got to hopefully someone order the 9-volt batteries. And you can find a 9-volt battery, right? Otherwise, you can take out the battery to your nothing uses 9-volt batteries nowadays. Anyways, maybe your smoke alarm, right? You might get your 9-volt battery out of that, right? You could off the ceiling. All right, she's like, why is Oscar up at the ceiling? I'm getting 9-volt from my pacemaker. Anyways, what's the next one here? This looks like VTAC because what? One thing is fancy is that we switched axis here. So it's flipped upside down. That's usually clue in it might be VTAC. But also we see what? I see some AV dissociation happening there, right? So this is leaning more, and it went from a narrow complex all of a sudden to a big wide complex. Okay. Sometimes when you have like SVTs, it's usually you develop a right bundle branch block. This is a left bundle branch block. And we can talk about left versus right another time, but what the difference looks like. But either way, this looks like VTAC. A little run of VTAC. Okay. All right, next one. What is this one?
Sinus rhythm.
Sinus rhythm, right? If that's sinus rhythm and you go in the room and they don't have a pulse, what is that called? That's PEA, right? So that'd be a problem because you can have PEA with sinus rhythm. That's allowed. All right. And then what's next? What do we have here? Definitely have some activity happening. Something this guy's happening there, right? There's P waves all over the place. What is this? This is not SVT, this is VT. This is ventricular tachycardia because this is like clues you in that you have ventricular tachycardia. We have one little impulse that made its way when the ventricles were going off, right? Or going off. Then we had one little complex make its way through. Right? That's called a little capture beat. It captured the heart right then and there. So you have a little atrial impulse that got in the mix of all this VTAC. And also we have some looks like some AV dissociation as well. All right, and then the last one, what's that? This looks like torsades for sure, right? And how do you fix torsades?
Shocking and electrolyte replacement.
Electrolyte, especially mag, and we'll shock it back if it doesn't resolve, right?